screen. File. Thank you. Good morning, everyone. How are you doing?
Good.
Okay.
What do you think about this ECG, Dong-san?
I think he is showing sinus rhythm, heart rate of 160 to 70, and showing narrow QRS pattern with RBBD. And I think it is supraventricular tachycardia, AVNRT or AVRT.
Anyone else has any different idea about different interpretations in this ECG, please?
균형 부위? I agree. This is metal first, and the below T and QRS, T followed by QRS contains good range. And with a review pattern. I also think there's possibility this is a benefit. Next, I think Phil want to say something to us.
This is the neural complex Italian people followed by QRS complex abbreviated and the QRS complex should be correlated with the sinus ECG.
So,
T and AVS is P wave is twisted by quartz complex.
QRS complex.
SVT with aberrant conduction.
So it should be correlated with the sinus rhythm, QV.
any other different opinion, different idea that we should talk? So can you summarize us what you guys said so far? And there's several different idea came through. So tell us what you consensus this is. Can you hear me?
Yeah.
Okay. So somebody said there's a narrow complex tachycardia, somebody said the aberrancy, and somebody said the sinus tachycardia. So what evidence do you have to say that this is a narrow complex tachycardia? Whoever said the narrow complex tachycardia, this patient had either right bundle branch pattern, so it's a wide complex tachycardia already, right bundle branch block. Whether it's an aberrancy or it's a VT, there still should be a complete right bundle pattern here. Your QRS duration is more than 3 bucks. It's 120 milliseconds or longer. So it should be wide complex right bundle, but you could argue relatively narrow right bundle branch block. And we talked to this about before. If you look at the lead 2, 1, and perhaps even AVF, during the QRS complex, you should not have any additional notching. Remember that? Because of your ventricles are depolarizing. So it's absolutely refractory. So cannot have any other additional noisy, notching, any changes. So if you look carefully, lead 2, what do you see? At the end of a QRS complex, there's some small notching, opposite direction of a QRS complex activation. So what is that? Is there a possibility, could it be another activity going on there? And that notching has a one-to-one relationship to the QRS complex. Do you see any other P wave?
No.
No. So differential diagnosis here, Dr. Park suggesting, could it be right bundle branch block pattern VT with the one-to-one VA conduction, or well-known famous SBT with a short RP tachycardia? Okay? Now, what determines SBT versus VT? QRS morphology. This right bundle branch pattern that you see on the screen is consistent with the VT or SBT aberrancy. I think that's a question we have to sort out. First thing, right? So how many of you guys think that this is a VT? Wide enough to be VT? QRS morphology right bundle is consistent with the VT morphology. If you say yes, you need to tell me why. If somebody said it's an aberrancy, then you need to tell me why also. Because this is some of the common questions you will face every day in your practice. So 2-minute think, tell us your opinion, okay? Looks like this morning ECG conference, you guys are all depressed. What happened? Supposed to speak out, okay? So let's vote. How many think this is aberrancy, or how many think it's a VT? Go ahead.
Aberrant.
So
Aberrant or anyway.
all of them aberrancy. Great. That's wonderful.
Or agree with that with me.
All agree that this SVT aberrancy. Is that correct? Am I hearing right?
Or if on the red block, I don't know, don't find that it.
Yeah. Okay. So what is a criteria to be right bundle VT? Usually when you read the EKG. So just a review of that. So your initial B1 right bundle pattern consists of VT or SVT? RSR prime is consistent with SVT, right? Not a VT. Unless you V1 initially is a Q. This is not a Q, RSR. So small r and then S and R again, which you can see better in D2. So this is a consistent with first criteria of SBT. Look at the V6 and V5. What do you think about R and S favor ratio? R is bigger than S, right? And then narrow, not wide. Therefore, this EGM is consistent with EKG aberrancy, right bundle. Okay? If we had a precordial concordance or either concordant negative concordance, that would be much more favorable. But this is the ECG favorable aberrancy. Okay, if it said so, then Lead 1 has a little bit of a deformity in the QRS complex. What are the differential diagnosis short RP tachycardia? Typically, you would see this in, as you guys already somebody mentioned, AVNRT is most common. What other tachycardia can do this? Can automatic junction tachycardia can do this? Usually, automatic tachycardia tends to be long RP tachycardia. But in rare cases, you still cannot rule out possibility of automatic tachycardia, junctional tachycardia. What are the difference between AV and RT and junctional tachycardia? Junctional tachycardia is automatic tachycardia. So they tend to be slightly irregular most of the time when you record the long recordings. And this tachycardia is regular or irregular?
Regular.
Regular. So there's a few, not 100% certain criteria, but a characteristic of tachycardia can suggest, you may say, P wave, retrograde P wave pattern versus AVNRT. We already sorted that out. Is AV most likely SVT. So high favor for AVNRT1. Number 2, possible cannot rule out junctional tachycardia, 1-to-1 retrograde conduction. And any other difference diagnosis, we should put it in here. AVRT, possible? It's possible, but unlikely. So then you're going to put that list in the bottom. So you have 3 differential diagnoses here based on the what we discussed. How many favor for AVNRT, first diagnosis? How many of you guys think it's AVNRT? Anybody against the first diagnosis AVNRT? Please tell us why, if it's yes. Second is a junctional tachycardia. Third is AVRT, but very unlikely. Okay, let's look at the history. What are the stories?
Patients was 63-year-old male.
Mm-hmm.
The chief complaint for heart transplantation. And he was transferred to Severance for heart transplantation after STEMI on May 30 at Wilson Hospital.
Mm-hmm.
He was in severe ischemic heart
Oh,
failure, rejection,
yeah.
reduced ejection fraction, cerebral disease, and LV thrombus. And he was
Can
arrived.
you? Okay, Dr. Park is sending you a message. Did you read that? Do you have a sinus rhythm ECG of this patient? You don't have a sinus rhythm ECG of this patient.
Yeah.
Okay, so Dr. Park answered your question. He does not have a sinus rhythm ECG. Okay, sorry to interrupt you. Go ahead. I'm so sorry. You should have a sinus rhythm ECG of this patient. So compare what it really looks like better. Okay, go ahead. Go ahead, yeah, present the case. You don't have a sinus rhythm. So next slide, please. Okay, I'm sorry I interrupt you. Okay.
Yeah, he was arrived on ECMO with venting. Initial vital sign, blood pressure was 104/90 at rate, and other like sorry, this is body temperature, and saturation was 100%. Transplantation was done before 2 days ago. It was May 30.
Okay.
And in ECG presentation, same time, chest X-ray was like that.
Okay.
And at that time, laboratory finding on severe leukocytosis with elevated neutrophil count. He was in AKI. At that time, he doesn't show oliguria, but the next day, he showed oliguria. He was in CRRT. And NT-proBNP was elevated. And other finding is actually amylase and lipase was elevated. One thing to think about is he was in raw bacterial infection from May 14, and with fever, CRP and procalcitonin elevation, but no definite finding on infection focus. And sustained leukocytosis, and inflammatory marker was elevated. At the same time, heart transplantation was done at May 30. So actually, I think about this, it might be post-op PHR fibrillation or AT, but I'm not sure about that.
Okay.
Yeah.
So if I may ask you a question, what kind of AT you're thinking? Is atrial flutter? Oh,
Oh,
or is what you're thinking?
in history, he was uh, he the medication at that time, adenosine, 2 times adenosine cannot convert the sinus rhythm, and
Okay.
it changed to atrial, looks like atrial fibrillation, or anyway, no converts to sinus rhythm after AV block. So I think it would be not AV NRT or AVRT. And after amyotrophic continuous diffusion, it converts to more regular, normal range of rhythm.
Okay.
So it is the
Okay.
yeah.
Minus rhythm. So what rhythm is in this patient? This EKG. Can you tell us what rhythm this is?
I think it can be sinus rhythm, but I cannot find the P wave.
Yeah, so then what's the rhythm is?
Junction. Yeah.
But it's a junction rhythm. Right? And then the EKG complex morphology. Lead to you have a small, that notching guy, end of a QRS complex. So what are the unusual rhythm you can find? Somebody read the sinus rhythm as well. Post-transplant you can find. Long time ago, we used to read EKG time to time. Post-transplant used sometimes see 2 different type of P wave. Is known as the dissimilar ECG P wave. So in other words, when they do transplant, all the technique, they don't do cabo-cabo connection. They used to do cup connection. That is, they maintain SBC in heart atrial junction, and they put a donor's heart in part of a section of a sinus node, and then they put a sometime together. So then you would have a 2 sinus rhythm activity going on sometime. Or sometimes that residual right atrium of the recipient's heart, disease heart, would have a tachycardia, and donor's heart to maintain sinus rhythm. So then UKG, you have a atrial flutter with P wave, or 2 different P waves, many different variation expression used to happen. But since the new transplant technology, with the technique they use, a cabo-cabo connection, that problem has been very rare and resolved almost completely. Exception of a patient's recipient SVC tachycardia can do that now. So what do you think about that possibility? Is that possible in this patient? This similar ECG pattern? So do you know a detail about this patient's surgical report of a transplant or no?
Actually, I don't know.
Okay, so you might want to look into that, tell us how they did the transplant, but I'm sure they did a cabo-cabo connection. So this patient transplant donor information also to be important, not the identification, but how old the patient was, how old the donor was, and who was the donor's gender, female, male, and so forth. Okay?
Yeah.
Adenosine negativity during the SBT, especially under extreme catecholamine surge, sometimes can be misleading. Still cannot rule out the possibility of AVNRT or any other mechanism of tachycardia. But based on the EKG pattern you presented this morning in sinus rhythm, maybe most likely, maybe junctional tachycardia, automatic tachycardia of some nature, that we put up at the bottom on the list. Now, tell us what else did you do interval management this patient?
He just infused after initial acute phase. Now he has regular heart rhythm, so no
Okay.
medication now.
Okay, so patient ever saw sinus rhythm recover in ECG or no?
This is the relatively recent ECG.
Okay. So are they, so
Yes,
tell me, okay, so then one more thing. Tell me how you're going to differentiate first, this is a truly automatic junctional rhythm or ectopic atrial rhythm, whatever it might be, versus a sinus rhythm. Is there any maneuver, any diagnostic testing you can do? First question, how many day post-op this ECG is? Do you know? When, since how long ago surgery?
3 days.
3 days.
Yeah.
Patient still has an epicardial wire, pacing wire, temporary wire?
No, I am no.
You don't know. Okay. As you know, many times surgeons, when they finish operation, they put a epicardial temporary wire, at least one in atrium, one in the ventricle. Those wires also can be source of your EGM recording at bedside. And they also can be paced, as you know. You can do quick pacing maneuver at the bedside, like what you do in EP study, okay? And then you can identify diagnosis, whether this is automatic tachycardia versus reentry, or junctional, and so on. So this is one caveat that if you have consulted to be in OR or either in the post-op recovery area or recent cardiac surgery, see whether patient still has an epicardial temporary wire, and then you can connect to your recording system. Even ECG machines can do that. You can hook up the, alligator clip. You can record, then you can figure out what is this rhythm is. So there's many tools you can use in post-op period in the patient. And you may want to do that if the guy has a temporary wire right now. If once a certain surgeons and nurse take it out that wire, you're lost in golden time. Okay?
Do you have a ECG during adenosine injection?
Okay, yeah. I think that was something that you were just going to show.
I want to find it, but no definite.
No, there was another tracing you just to show briefly. What was that? Wasn't there another tracing? This is all your slides?
Yeah. The next is this is the last slide.
Yes.
Sorry.
Okay. This. Let's take a look at that. This is now. Okay. But looks like this is a EKG with atrial fibrillation pattern. There's not really much anything pattern here. Even though time may regularize, but it looks like a mostly irregular. Now,
Can you see the first ECG? I can see the P wave like wave just before QRS in lead 3.
also you see in lead 2, but they are not correlating one-to-one relation time-wise. They looks like almost marching through. I was looking at that earlier, but then I don't know whether there's a two different type of rhythm going on, or this is some sort of a junctional tachycardia that dissociates P wave. Possible, but cannot make it 100% sure. Because the baseline is a little noisy, wavy. Okay. that round P waves, kind of a come and go in and out of QRS complex. So could it be a atrial flutter 2-to-1 conduction, subtype atypical flutter? Is it possible too? But the small notching at the end of a leader 2 is really a little different amplitude than what you saw in sinus rhythm. That small notching is much smaller. So I don't know whether there's a summation or additional rhythm there. It's not certain. Can you go back to that atrial fibrillation EKG? Okay, here. So patient looks like it has also intermittent PVC. Correct? I think that's PVC. And the also you have some fusion bit on the that guy. That's a fusion bit. And then also patient changes time to time different QRS axis. If you look at the rhythm strip leader 2, number 4 bit, come to the right. Next one, that one. So change the complete different axis. This is purely R wave, and then that's transiently change. So I think this is probably atrial fibrillation with the intermittent fusion, different degree of fusion going on with the PVC. So I think these questions, certainly can be determined by the bedside diagnosis by just hooking up the temporary wire in atrial AGM, and then you will see what's going on with the patient. That help you to manage. So instead of just pushing amiodarone, things like that, you gather that information and you will make a better decision what to do with the patients. Okay?
So I wonder, the small notching just at end of QRS, is there possibility the small notching is part of QRS?
It's possible too. But if you look at this atrial fibrillation EGM, the notching is not pronounced as the first ECG you showed to us. There's intermittent notching. The question is that if there was a flutter 2-to-1, then got to be very fast flutter, or what we call atypical flutter. Because your tachycardia rate is much faster than typical flutter rate we see. Certainly the possible patient is in infections and post-transplant, all this issue. But right now I can see some notching also in the T waves, in the V5, for example, and on top of a T wave. So those are probably ectopic atrial rhythm of atrial flutter fibrillation wave going through. Okay, you're gonna update us to see how this patient will recover sinus rhythm or not. That would be also interesting to know.
Okay.
Okay. Anybody has any other comment? Anything else?
Please show us the ECG during adenosine injection.
Okay.
Yeah, probably ECG may can be found in an ICU ECG monitoring.
Okay, so you can maybe bring the tracing of that. We'll take a look at it. Okay, Dr. Park asking question. Do you hear that? This read his message? This could be possibly dissociated P wave. What do you think is that possibility? So I assuming that you have two different rhythm dysrhythmia, dissimilar ECG, or either patient in junctional tachycardia with dissociate would be very unusual for normal donor's heart. So would it be interesting to know what the donor's condition is also, because very unlikely though that they would not select that kind of patient for transplant. I think we've seen patient donor heart had SBT and left side concealed pathway, and even WPW. Sometime in the past, surgeons miss and in transplant heart. Donors heart had axillary pathways, but
I wonder the anastomosis site of the right atrium or left atrium.
Okay, fine, thank you. And in June 2 ECG, rhythm strip, I see the more precise design. There was more P wave.
yeah, we see very slow P waves marching through from time to time. Dr. Park, that's what he's asking, especially rhythm strip at the last second beat, preceding second beat, there's a small bump P wave. But also, right following that, the S segment, there's something else as well. And so if your patient has a very low amplitude atrial activity sometime, you cannot interpret it precisely. So this, you could argue with the patient could be almost low amplitude P wave throughout, or some sort of atrial rhythm with the junction escape rhythm. I think that's a question of Dr. Park, because your RR interval is slightly irregular, but I don't know whether that is 100% sure. That's why I suggest you get an epicardial read recording to be sure what we are looking at. And then other possibilities, what? Could there be atrial standstill? That's another possibility. The patient is very unstable post-op. So that would be interesting to see it. Okay?
You can find out a very small P wave in the rhythm strip. Here
Yeah, that's a P wave.
and
Yeah, right there. There is another one.
yeah,
And then there's another one, the top of a T wave too. So it is possible to junction with the dissociate. It's possible.
so we need to measure the PP interval. This one.
Doesn't match. They are not interpolated or neither regular, looks like. But again, you're possible, but we are not sure. So I think better read it as what you see, probably junction rhythm, and then go from there. Whether what is a P wave we're doing, dissociated, marching through, or there's something else going on. Because your amplitude ECG is, if you notice, lead 1 to 3, extremely low, this patient. So another possibility is that the transplant relay the acute inflammatory changes, acute rejections, things like that. You need to think about it. But this is too premature to discuss any of those because it's too early to say. Okay? Any other comment? All right. I think it's already 30 minutes.
Thank you. Thank you for your
Thanks for your case.
This is Junyoung Ri from Severance Hospital, and I will start today's EGM conference. Okay, the patient is a 28-year-old male with congenital heart disease He was born with a functional single ventricle and AV septal defect and pulmonary stenosis and ASD and bilateral SBC. He had got bilateral gland shunt at 11 months old and Fontan operation at 2 years old. This illustration showed the heart is born with. Only one ventricle works and pumps blood to both lung and body. But there is no arterial septum. Blood from lung is mixed with blood from the body. So there are sinuses and volume overload with this type of anomaly. And right side image showed bilateral gland shunt. He's got 11 months old. In the procedure, both side SBC were connected to each side of pulmonary artery to decrease the volume overload of common ventricle and help oxygenation. And this is the patient's record of Fontan operation that he's got in 2 years old. The operation was lateral tunnel Fontan operation. In this operation, conduit was used to make close ASD and make tunnel. And they connect IVC to pulmonary arteries. In this patient, conduit is one on pericardium, and it was sutured with the right arterial wall, separating heart from IVCT, pulmonary artery. So is a report from pediatric cardiology for evaluation and management of new diagnosed arterial flutter. Because his heart function is getting worse and worse. Tachyarrhythmia-induced cardiomyopathy was considered as a cause. This is a 12-lead ECG, arterial flutoid variable block. And this is X-ray. His echocardiography showed AV valve regurgitation because of poor coaptation and severe systolic dysfunction. This is CT. The anatomy is abnormal, so CT gave you the important information. So this is ascending aorta and right and left SBC. And this is root of aorta. And both SBC connected to right and left pulmonary artery. Loaded. Okay. This that shows common ventricle and rudimentary ventricle. And there is a common atrium behind it. Right to atrium is Fontan conduit. And this part of conduit is made of is one on pericardium. And it's separating the atrium and the Fontan tunnel. And we can assume that the suture point between natural right arterial wall and pericardium is about this point. And this is functional ventricle. So we can review the CT again. So EP study was started to treat atrial flutter. If we would want to get into his heart, Fontan conduit should be punctured, but we didn't want to do that unless it's necessary. So initially, just one decapolar catheter was placed in his left pulmonary artery. We use this as a reference catheter for the activation mapping. Right jugular vein was used to show that any other catheter couldn't touch the reference catheter. And Fontan angiogram was done to check anatomy. Initial rhythmus atrial flutter with 2-to-1 conduction, tachycardia cycle length is 239. And this is a 12-read ECG tachycardia. So local activation mapping was done using octary catheter. During mapping, we can see the double potential at some points. This is current map. And we assume that this point is a critical isthmus. Okay, so it's the same point that showed the double potential. And when comparing with the voltage mapping, we assume that this point is in the atrium pericardium suture line. But during the activation mapping of burst atrial flutter, tachycardia cycle length was changed to 241 to 206. We thought that it's the second atrial flutter and did the activation map separately. And we also find double potential during mapping the second atrial flutter. So this is a current map of second atrial flutter. The current map and double potential suggest the potential point. The points below the first point, we thought these were also in suture line. Okay. ICE was done before starting operation to check anatomy and intracardiac thrombus. An ablation catheter was placed to target this point. ICE showed the ablation catheter was touching the conduit wall against common atrium. This was pre-ablation signal, and ablation was started. There was no change in tachycardia during first ablation, so we moved the ablation point to the second point. And during third ablation, cycle length changed again to the longer one. And during eighth ablation, the tachycardia terminate with this APC. And after ablation, basic EP study was done. RIP 320 was the AV blood cycle length, and single arterial test 600 and 200 was the AVN ELP. During tachycardia, during EPS, no tachycardia was induced, and we decided to finish the procedure. This was the normal sinus rhythm after ablation, and this was the 12-lead stage after the procedure. And after procedure, we hope there was a improvement in function, but his ventricular ejection fraction is still bad and still get heart failure management. And thank you for your attention. This was the end of my presentation.
Thank you for your presentation, Christian.
Can you hear us? Do you have a minute for tell me a few things? So, what made you decision to put your reference catheter to the left pulmonary artery? Am I understanding correct this? Right?
Mhm.
Why did you put it in there?
I would like the reference catheter to be stable,
So it's just a stability issue.
stability, and
Okay.
I don't want to touch
Okay.
those catheter.
So understood. If you had this catheter obviously covering, I assume, roof of your native, whatever, single chamber anatomy, upper chamber, part of pulmonary artery, I can see. Now, did you consider pulling back your reference catheter to closer to the fontaine during the procedure? In other words, pull it out a little bit more closer to the your chamber that you're mapping. See whether that could help you to increase accuracy. The reason I ask that because a lot of your signals are far field.
Yes.
So that would be something that may improve your map a little bit. Okay? So that is your signal, correct? Am I right? Reference catheter?
Yeah.
Am I wrong? So you have only two channel. The activation sequence is proximal to distal. Am I right?
Yes.
That well, if you pulled back, if you had the reference that had covered longer tachycardia duration, at least part of a tachycardia cycle, may give you better reference. I think that's first comment I want to tell you. Because your reference is compared to the intracardiac mapping that you did beautifully, is all far field. So that is, I think, it was something that you may want to think about doing next time. So display all 5-pair electrogram, even though far field, probably they give you a little more confident what you're mapping. Now, second question I have, could show us the tachycardia map there again, please? Yes. So what percentage of tachycardia cycle length did you cover from the mapping in the Fontaine conduit? Entire tachycardia cycle length, or there was some missing cycle lengths here? Initially, the 240 you told me. Am I 230 or something like that? 220? So you cover 95% plus, I assume? Is that right or no?
Not 100% was covered.
Was it 100%? So 245 looks like a tachycardia cycle length. Is that what it is? Right there?
Yeah, this is 240.
So now the area that you show this map here, and there's a if you will, Fontaine patch breakthrough, I see. Am I correct? Am I looking at this map right? Right? So it would be better if you had a small puncture on the Fontaine. Since it's a pericardial patch, your operative report says, right?
Yes.
And map the left atrium as well would not be elegant. or you think the risk is too high? What do you think? Because what I see is just the breakthrough point turning around, your propagation map, and then there's a gap for a while, and then breaks, fire again, but posteriorly. So I'm not sure whether critical isthmus could it be. I assume that black down mark is a scar tissue. Am I correct? Yeah, that area without no color. Yeah, right there. So that's why I think I assume you consider two spots that potentially cause a connection.
Yeah.
Yeah, so I just wondering is that, how comfortable would it be based on this map, you ablate this flutter? If you go back, let's go back to your ablation signals, and that may tell you a little bit about that. If you look at your first ablation that you show us a little bit, look at this signal, ablation signal. Yeah, again, this ablation signal is a much more far field compared to your TECA-NAVI 910 EGM quality standpoint view, even though early. And second point is that I'm not sure this study is earlier than proximal. It looks like this study is a little bit later than proximal to me. If you look at that mid right there, there's another ablation distal signal a little bit. You can see it. That looks like a later than proximal. And that appears to be a little bit of a Q. And the proximal has a very tiny R. So I wonder whether your ablation in the proximal site would be better here than distal, but they're still far field. So I'm not sure how do we conform. This is truly tachycardia critical isthmus without doing some sort of a EP pacing maneuver like entrainment, some sort of a maneuvering. As you know, 3D mapping can mislead a lot of time. So I think that's the first thing that I would have done, try to get a better EGM to entrain before you apply energy into it. And if you look at the second site ablation EGM you showed to us also, take a look at it, please. You can see this is the second site now or first site ablation? RF3, the first site, correct? EGM is what was it?
Is termination site.
The termination site. So if you look at your tachycardia terminated by how?
APC.
APC. So that is a tended to be sometime less responsive RF response than slow gradual termination of tachycardia. Because this is a re-entry mechanism, I assume any APC can terminate tachycardia. So I think, that's a concern. But certainly your post-ablation after termination, you can see it's double potential with the conduction block. I can see right there. No, go back to EGM RF, right there, the first complex sinus rhythm. You see initial component is negative QS. Second potential right behind the ablation distal signal. Take a look at it. Small sharp potential is R. So go to ablation distal. Yes. First component of that. Yeah, that's a QS. Next, right behind, double potential, small one, back, go back. Yeah, that's a positive. So there's a conduction block here. So I think that might be considered as a good response. Okay? Which precedes also your sinus QRS complex there. So I think sometimes, trying to be conservative, we can understand, but sometimes you absolutely needed to map other area as well to make sure that there is no other issue. Third consideration is that obviously when you intervene congenital heart disease, I think there's a lot of risk involved, difficulty and challenges. But we have now small two French catheters. I'm sure Dr. uses a lot of time. You don't need to make a big puncture. You can make a small puncture. You may introduce a two French catheter through that hole, and then maybe small angiographic catheter, 4 French maybe, and you can manipulate catheter to try to figure out native atrial chamber, what is going on. Sometimes might be more illustrative, and sometimes procedure time can be shorter. So those things I think, you need to think about it. Because when we used to do this when cardioma era, we had a 1.4 French catheter. So we able to put it in most of our congenital patients, very difficult vasculature without significant insult to the heart or creating some ASD hole, things like that. So it has been useful. And after that, they got rid of the catheter, so we couldn't do anymore. But that's something to maybe think about it. Any other comment? And it's wonderfully done with a limited technology, unitary mapping. That's great. Okay, so almost time is up. Hopefully you guys have any other question, any comment, please ask us. Professor also will be able to answer. And I think it is an opportunity for us to review terminology as well as anatomy of a congenital heart disease. So did they isolate a right ventricle, primitive right ventricle, or my left ventricle? Did they isolate it? Dr. Om, do you know? I see some calcification on the annulus, on the CT. Did they exclude that chamber? What did they do? If you look at the CT, look at ventricle, the undeveloped ventricle.
He has a single functional single ventricle.
Yeah, but then there is some cavity there in the CT. Take a look. CT scan right here. I think you showed to me. Yeah, that you see that small rudimental ventricle, and then there's a calcification right top of it. What did they do? They isolate that thing or what? They just left alone. So there's
Surgeon did not any perform the
any.
procedure.
Okay. Oh, I see.
Ventricle.
Oh, so they're left alone then. That's why you still have some contrast in there. Okay. All right.
The doctor has a question.
Okay, Peyton. Okay, great.
He has been the ablation
Mm.
and two cyclings.
I see.
Yeah, show different, maybe different registry. And but first 30 cyclings was bigger, more longer than second cyclings. So in my opinion, shorter cyclings have to dominant than longer cyclings.
Mm.
In my opinion.
Okay.
Is there any reason or is no matter? Because shorter cyclings when reentry, it's signal have to it's signal going through and you have to refractory time. So slower cyclings reentry cannot conduct to the atrium.
As I understand your question, you are wondering why the atrial flutter with the shorter cycle length was not dominant
Yeah.
at the beginning.
Yeah.
The procedure.
Yeah.
Right.
Yeah.
I think the first tachycardia with a longer cardiac cycle length was dominant at the beginning of the procedure. However, during the mapping, we touched the atrium, atrial tissue, and you may not, we may touch the reentry circuit, and the reentry propagation circuit may change it to another circuit. So that's why the tachycardia was changed during the atrial mapping. So he has a lot of scar tissue in like atrium. So there might be lots of possibility to multiple reentry circuit, and we may modify the reentry circuit by touching the atrial tissue. Why the circuit was changed. another circuit.
I think this patient has 2 tachycardia circuit. Answer lies on your tracing. Go back there. If you look at to go to tracing, EKG, EGM, go to show us the tracing. Keep going. Okay, hold that for a second. So okay, show us that slide. This is a reference. Go back. There was a one that before that, I think, or above. You just showed to me. Okay, click that. No, that's one. Next go. Well, the intracardiac EGM mapping catheter. Keep going up and down. Let me see. I think there was a real reference EGM change. Show to me. Okay, maybe around there. The I is in the EGM. Okay, right there. Maybe this one. No, this is okay. If you look at this flutter, look at the DECA 910. Here is a reference. It's very stable, single morphology, right? And if you go down and where the tachycardia changed, keep going down. So I think it's following this second atrial flutter activation. Keep going. Okay, one more maybe. Next slide. This is you're referencing. Okay, keep going.
This.
Next one. There's another one I think has a EGM. Your reference EGM changed. Okay, just past one maybe. Because your that can have a 910 EGM change completely. That I think that one. You're just sliding that. No, that one between atrial flutter 2 to 1. No, atrial flutter 2 to 1. Okay, right here. Look at this reference. If you look at that can have a 910, first 5-bit, same morphology, right? Then what happened? Gradual change to the different type of EGM. That can be 7-8. Take a look at the EGM. They're not same. Activation sequence change. Also the slight morphology in EGM. This may suggest that there's another tachycardia circuit. Okay? So that's why I ask you about putting a reference in the good place, because they can appreciate this change much more. Appreciative, impressive, and faster. So that's why in congenital case, reference Dr. mentioned, very, very important. Stay stable, especially limited access, and should appreciate all the EGM much as you can. Okay? Anything else?
Any question from the floor?
Okay, I guess we are done. Thank you very much for the wonderful case again. And
Thank you.
tell us about that transplant patient, how the patient doing. Because the QRS complex amplitude is very low. We are worried. Usually post-transplant patient, QRS amplitude is such low, you need to start worrying about Q2 rejection, all other complications. Okay, I'll see you next week.
Thank you.
Thank you so much. Have a good day.